Well, hello, ladies and gentlemen. Welcome to our Osteoporosis Forum tonight. My name is Sonia Feldhoff from ABC Radio Adelaide, and it's great to see you all out tonight. Congratulations on braving weather conditions that would keep the faint of heart at home. You are obviously the brave, strong lot in our community. Good on you. We are here at an Osteoporosis Forum for Women's Health Week, but it is great to see so many men here because, of course, osteoporosis affects all of us, but women more severely and more particularly in some cases because of our makeup, and we're going to learn a bit more about that tonight. We've got a great range of speakers who are going to look at this from a medical position, from a dietary position, and from an exercise position about the sorts of things you may have control over, the sorts of things you can help gain some more control over in relation to this condition called osteoporosis. Now, I don't know about you, but I've heard the name all the time, but do we really know exactly what it's all about, what it can do for you, what it can do to you? These are the sorts of things that you need to know to make sure that as you age, you can age in the best possible way and live your best possible life. Now, a couple of years ago, we had our first forum of this kind on menopause, and it was really successful. So it is great to be able to bring this to you again, and we can only do that thanks to the work of a lot of people who've been putting some real strong efforts into this, including, and most particularly, I might say, the Multicultural Communities Council of South Australia. So thank you to them. We can also thank Healthy Bones Australia, the National Council of Women, Soroptimist and BPW Adelaide, plus my own employer, ABC Radio Adelaide, that has supported this. So thank you. Now, when it comes to our session tonight, we're going to give you the chance to answer questions at the end of the night. So you will get a chance to put your questions directly to our guests who have the expertise. We'll have microphones going around the room. Hopefully you'll get a lot of your questions answered that you've come here with tonight by the presentations that you're going to see. But keep those questions ready to go because we'll give you that opportunity. Just remember though that all of our experts here can only give you advice in a very general nature, okay? So if you've had a particular situation, you've got a particular condition, we're not going to be able to answer that directly. We can talk around about some of the issues, but you can't have a personal consultation, basically, right here and now this evening. That's going to be a little bit difficult without knowing all the other facts around your particular condition. Anyway, let's get started because we don't want to waste time. Let's introduce our first guest. She is a woman who is able to make the difficult seem simple. She brings it into the everyday. If you are not a doctor, a scientist or anything like that, you won't struggle at all because Dr. Jane Elliott has a great way with words to really make things very understandable. She currently is with Aware Women's Health. She's the clinical senior lecturer in the discipline of obstetrics and gynecology at the University of Adelaide. But she's been a GP in Adelaide for many, many years, practicing specifically in women's health, including menopause and osteoporosis, which we're talking about tonight. She also is a clinical senior lecturer. I think I've said that already, in teaching medical students and GPs. She's going to dumb it down for the rest of us tonight, hopefully. And she's been an investigator in clinical research trials in all areas of women's health. That includes menopause, contraception, osteoporosis and low libido. Jane is the past president of the Australasian Menopause Society and a member of the Healthy Bones Australia National Consumer and Community Advisory Committee. Can you please put your hands together? Welcome Dr. Jane Elliott.
Thank you very much, Sonia, and thank you all for coming tonight, everybody. It's really exciting to see so many people interested in this topic. I'm really interested in us doing some prevention as well as talking about treatment. So, this is what we're going to be talking about today. What is bone health? What's this thing called osteoporosis? We'll be talking about calcium, vitamin D and exercise because I know you're all interested in that. I've got my colleagues, Louise and Erin, who are going to do the hard lifting there. Risk factors for osteoporosis. How do you know that you might be at risk for it? How do you diagnose it? What are the medications? And tonight I will be using brand names as well as the ordinary drug names for the medications because I think it actually makes it easier to understand. And what's the role of your GP and other specialists that you might encounter? And how do you get more information after tonight? So let's start with what osteoporosis is. And we've got a definition here which says when bone structure becomes weaker and less dense and the bones have an increased risk of breaking. So that is what it's all about. If you've got osteoporosis, it doesn't matter unless you break a bone. You wouldn't even know if you've got a very low bone density unless you actually break a bone. So that's the final end result, as we say. It's a bit like, think about it, lots of people might have blood pressure problems, hypertension. Mostly we can't feel that. The problem comes when that hypertension leads to a heart attack or a stroke. They're called the end points. So that's what we're worrying about, is preventing this end point of fracture. But I do want to make it clear, because a lot of my patients, and for that matter, doctors as well, get mixed up between osteoporosis and osteoarthritis. So I just want to be clear, arthritis happens at your joints, so the wrist, the elbow, the knee, hip, in your back even. So that's arthritis, which happens where the bones click to each other, and that you can feel ahead of time. You can feel the pain of arthritis. Osteoporosis doesn't happen at joints. It happens to the bones in between. It's a bit confusing because when we say we have a wrist fracture, it's not actually happening at the wrist joint. It actually happens a little bit up from the wrist. If we're talking about a hip fracture, it doesn't happen at the hip joint. That's where the arthritis is. The hip fracture is actually just a little bit down the leg, just in the long bone of the leg. So osteoporosis is not the same as arthritis, and it happens within the actual bone structure. I hope that makes it a bit clearer. There's something called osteopenia that you'll hear about. Osteopenia just means your bones are heading towards osteoporosis. And these are just medical definitions that are taken from a bone density test. Now, the interesting thing is that both people with osteopenia and osteoporosis are at increased risk of fracture. And if you've had a fracture over 50 and it's what we call a low trauma fracture, it means you've just slipped over a hose in the garden or off the curb. Once you've had a fracture, irrespective of your bone density, irrespective of whether it's just low bone density, osteopenia, or true osteoporosis, medically it's actually osteoporosis and you need treatment for osteoporosis. So it still counts even if you've just got osteopenia. But it is that level heading towards osteoporosis, and it's incredibly common in Australia for people to have osteopenia, slightly less common to have osteoporosis on a bone density. So we've got the numbers here from Healthy Bones Australia. Over 1 million Australians right now have osteoporosis. That's either they've got it diagnosed because they've got the osteoporosis on a bone density, or they've had a fracture. 66% of adults over the age of 50 years have osteoporosis or osteopenia. So just looking around this audience, I'm not making ageist judgments, but I've got a few little tiny weeny people up there, but I reckon most of us are over 50. So 66% of this audience have low bone density, which is amazing, isn't it? Because lots of us wouldn't realise that. And around 200,000, or here 183,000 broken bones each year are due to poor bone health. Imagine all the admissions to hospitals, going to your GP, and all of the lengthy time with rehab, all of that sort of thing that is happening because of this bone. So we can not only treat this better, probably, we can prevent it with your help and your awareness. So we've got some patients here that are just examples of the sort of people, because it can range. It's not just sort of an older person in a nursing home that has osteoporosis. So here's an example of Andrea, who's only 40. Her sister broke a bone, and her sister said to her, maybe you better go and have a bone density because it runs in families, so that's important. She was shocked to find out she had osteoporosis. She might have had something like premature menopause that could have led to that. We've got Kimberly here, who experienced a very rare complication after pregnancy of having osteoporosis. And what can happen is when a woman's pregnant, basically that baby sucks out all the calcium out of the woman at the expense sometimes of the woman's bones. So it's a rare complication, but it's possible. We've got Carol here. She used to get a huge amount of back pain and went to all sorts of different doctors, including GPs and other specialists. I'm not quite sure, nobody ever did an actual scan, but it took her an emergency visit to an ED to be diagnosed with multiple vertebral fractures. That's in the spine. And we've got Renee here. She's been receiving cancer treatment. It could have been lymphoma or breast cancer. She just tripped on her deck at home and she required surgery for a break. And it was then she was discovered to have osteoporosis. So could be all sorts. And I'm sorry I haven't got a man picture here, but basically 1 in 3 women over 50 in Australia will have an osteoporotic fracture. So 1 in 3 women in the audience over 50 will, 1 in 5 men will have a fracture. So certainly men get osteoporosis as well. So what can we do to start looking at this issue of bone health? I'm sure you've all got in your headspace vaguely the idea that calcium, vitamin D and exercise are important, and I'd like to add in there to the dietary, number 1, protein in terms of your muscles, because your muscles matter just as much as your bones, we're discovering. I'm going to largely leave these topics to my colleagues, Louise and Erin, because they're much better at it, but I'll briefly go over it so we get it in perspective. So calcium, 99% of the body's calcium is in the bones. That's where it mainly is. And diet, just a basic thing. Yes, there are calcium tablets, but we would prefer you to get the calcium from your diet if you're able and willing to basically use dairy products mostly. Most calcium in our diet comes from dairy products. And it's healthier to get your calcium from diet if you can. If you can't do that, some people can't have dairy products, then it is acceptable to use calcium supplements, but we don't want them to be too high because they can have effects on your heart and other cardiovascular risks. So you keep the supplement dose way down there, best to have that from diet, and Louise will talk about that further. You've probably vaguely understood about vitamin D. Vitamin D comes from sunlight on your skin, and the way vitamin D helps with osteoporosis is that if you don't have enough vitamin D, you don't absorb the calcium you're having in your diet in the gut. That's the importance. So you can be popping the calcium in, but if you've got a low vitamin D, it doesn't get absorbed. So you've lost that calcium. And although we've got a map here and you've all got the brochure from Healthier Bones Australia about how many minutes sunlight you might need, we're so careful now, aren't we, about slip, slop, slapping and keeping out of the sun for skin cancers that many of us have a low vitamin D. You can ask your GP to measure this if you have risk factors for low vitamin D, and quite a lot of people end up on supplements, just a single vitamin D capsule daily or once a week. We don't think the mega doses every 3 months are necessarily the best way to go with that. And again, I'll leave this to Louise to talk about. I will just say we're talking about doing a blood test for vitamin D, which is accurate. People often say, well, my doctor's done a blood test and my calcium levels are normal. Problem is that doing a blood test for calcium isn't accurate at all. Your calcium in the blood is always normal. If you've got an abnormal calcium in your blood, basically you're having a seizure. So calcium has to be normal in the blood the whole time. It stays normal by your body extracting it from the bones. So a normal calcium on a blood test doesn't mean you're having enough calcium. So exercise, and I really will leave this one to Erin, except to say that all of you who are doing walking, swimming, bicycle riding, terrific, well done. It's really good for your cardiovascular system and weight control. It doesn't do much for your bones. And that's why we've got Erin here to talk further about what we really need to be doing about your bones, because it has to be specific. So how do we recognise osteoporosis? I've got everybody worrying about it now. It says here not a silent disease. I think it is largely silent because unlike arthritis where you might feel a bit of an ache at your hip joint or whatever, you can't feel it. You can't feel a bit of an ache in your hip bone or your hip femur here, and that's osteoporosis coming. You really don't feel it until you've fractured. You can feel it in your back, but really only once your crush fractures in your vertebrae are happening. So in your spine, You know, you've got little rectangular bones, which are the spinal vertebrae. When they get osteoporosis and get a fracture, they don't break in half, they just squish down a bit. That's called a fracture, and that's where you get the sort of little old lady curved over look. That's painful, so you can start to feel it, but by then you've already got your fracture. Losing height matters. If you've lost more than 3 centimetres in height, that could be osteoporosis in your spine. That's a sign to get a bone density. If you break a bone, that's a definite sign. And the other thing is if you've got risk factors for osteoporosis. So what do we mean by that? There's a huge list here, but I will go through them in a little bit of detail because these really do matter. And I don't think I meet many patients who haven't got a risk factor or two. The biggest risk factor is just getting older. So most of us come to that if we're lucky enough. So age over 70, the government provides free bone densities for everybody. Just because they're not free below 70 doesn't mean you shouldn't be having one though. So everyone over 70 should have a bone density. If you've had a previous fracture, that's a red flag as well. Your bones are already saying they're fragile. So let's try and prevent the next fracture, have a bone density. I've mentioned the family history, particularly of a hip fracture, the loss of height I've mentioned. Now sadly, alcohol and smoking are definitely risk factors for osteoporosis, so they can increase your risk. And we've already talked about the calcium, vitamin D and exercise. So all of those things in that sort of personal history are things that we should think about if they're happening. Go to our GP and say, maybe I should have a bone density. There are medical conditions, and there's more than this list, but these are some of the big ones. Celiac disease, that's where you don't absorb wheat properly. If you don't absorb wheat, interestingly, you don't absorb calcium, and that can reduce your bone density. Thyroid problems, your thyroid's in the middle of your throat, so an overactive thyroid can do it. And parathyroids are 4 little glands that sit in your neck around the thyroid. They influence calcium metabolism. They can cause trouble. The rheumatoid arthritis, so that's the sort of more serious inflammatory arthritis, not ordinary ageing osteoarthritis. I've already mentioned early menopause, and also low testosterone in men can influence bones. Chronic kidney disease, chronic liver disease, and diabetes is an interesting one because people with diabetes can have fractures at sort of not as low bone density. So we don't count the bone densities in terms of someone with diabetes. We don't wait for that to get very low because they can fracture, at a higher bone density. There are many medications that can influence bones, but some of the big ones are treatments for breast cancer, treatments for prostate cancer, and then glucocorticoids. They're the steroids, things like prednisolone, that we might use not just a short course for asthma or something like that, but if you're needing, say, a long course of prednisolone for something like polymyalgia or something else where you're required to, or even for rheumatoid arthritis, that can influence your bones, and some of the anti-epilepsy treatments. So you can see there's rather a lot of risk factors there, and if any of them apply to you, it's something to at least go and take that information to your GP and say, should I be having a bone density? And re-looking at calcium, vitamin D and exercise in a way of preventing the next or the first fracture. So I've talked about a bone density, so let's just talk about what that is. I reckon quite a few of you may have had one of those, and I just want to go through what it is because we don't necessarily like having medical tests, do we? It makes us all a bit twitchy, but a bone density is an X-ray of your bones, but it's incredibly low radiation. It's about enough radiation for, say, half a tooth. So you know when you normally have X-rays, everyone covers up and leaps out of the room and leaves you in the room with the radiation. With this, you keep all your clothes on, nobody touches you, nobody is going to inject you with anything. You just lie flat on a bed and a beam comes over the top of you. And as you can see in the top picture up there, the technician stays in the room with you because it's such a low radiation. We then do this bone density on your hip, your spine, and sometimes your wrist, because they're the areas we're worried about. And again, when I'm saying that, I don't mean the joints. We're not looking for arthritis. We're looking for the bones adjacent to those. We get something called a T-score, which basically tells us whether you've got osteopenia or osteoporosis, or hopefully normal bone density. However, we all lose bone as we age. So it depends where you are on that graph as to how vigilant you really should be being with all the prevention. I think we all should, really. If you do break a bone, I've already said, if you break a bone because you've, I don't know, fallen out of a second-storey window or you've been hit by a bus, that sort of fracture we would expect to break, wouldn't we? That doesn't count as osteoporosis. Osteoporosis is where we just, as I've said, trip and fall, I don't know, step in a little rabbit hole and trip over. 5 minutes, thank you. And that's when you should be thinking osteoporosis. So who can help you with this? Your GP is the #1 specialist to go to. Osteoporosis is really common, but you know, in defence of GPs who are constantly being told they're not doing enough and they're missing this and they're missing that, GPs have to be across about 187 different conditions, and this is only one of them. So you need to help your GP, and if you think you might be at risk, go and talk to them about it and see whether they'd like to work with you on this. There is a lot that can be done, both in terms of prevention, but if you've had the first fracture, often the first fracture is a wrist. You fall over and put out your wrist to prevent a fall. Let's prevent the big ones like the hip. Like other chronic diseases, if you have osteoporosis, you do need treatment mostly for life. And I've listed the medications here that can be used, and I'll just briefly use the names because then you'd be familiar, because there's not many medications for it. But once you have osteoporosis, it's not enough to do calcium, vitamin D and exercise. So the good thing about women, there's a few good things about going through menopause, and one of them is that there is treatment. If you are someone going through menopause and you, say, have hot flushes or something else and some osteopenia, the menopause hormone therapy that we can prescribe works as well as any other osteoporosis treatment. So that's good. There are drugs specific for osteoporosis. Men can't use that, by the way. Drugs specific for osteoporosis called the bisphosphonates. They're either weekly or monthly tablets. You would have maybe heard of brand names called Actonel or Fosamax. There's an annual infusion of a bisphosphonate called aclaster or zoledronic acid. Most people now are using a drug called denosumab or Prolia, which is a 6-monthly injection. And there are other specialist medications which we can use. They all work about the same. They all keep bone density stable. They don't necessarily increase it. But what we're trying to do is stop the further drop. So we've talked about going to your GP. There are other specialists that you might be referred to, endocrinologists or rheumatologists who also deal in osteoporosis. And sometimes if you've gone to hospital with your first fracture, the orthopaedic surgeons might start you on something. But it all comes back to the GP and the community. So be aware of this. You're all here, so you win because you're all now aware of it. You'll have got the brochure that Healthy Bones Australia has given you. And we're now going to talk about the exercise and nutrition. I don't think I'll repeat myself there because I'll keep on time. One more thing, the Healthy Bones Australia website has good information, but we've got a little quiz you can do there called Know Your Bones. So you can put in your own individual stats and that sort of thing and see what sort of risk you might have to see whether it's worth going and speaking to your GP. So the questions we'll leave till the end because I think often the questions are the area in which you find out most of the information. Am I on time, Sonia?
You're perfectly on time, Jane. Well done, Dr. Jane Elliott. Isn't she great? She makes it so understandable. As we said, we're going to come to questions in a moment, but there is more to all of this. Diet, exercise, all of this plays a role. I've just come from the Royal Show. I've been broadcasting my afternoons program at the Royal Show, and I'm a little bit worried introducing a dietitian because to get here, I quickly grabbed a bag of cinnamon donuts on the way here, so I'm guessing that's not really on the list of good diet items, Louise, is it, for osteoporosis? But anyway, see if I pay for my sins by having lots of guilt as we talk tonight. Louise Mudge is going to join us now. She is a specialised dietitian at Adelaide Gastrointestinal Specialists in Eastwood and Gastroenterology SA in North Adelaide. Try saying that quickly. She has 25 years' experience both in private practice and in her previous role as a senior dietitian of digestive diseases at the Royal Adelaide Hospital. Now, she was recently, I don't know whether we're going to hear about this study, Louise, because I'm fascinated by what this involves. She was recently involved in a study testing the reliability of body composition analysis as a measure of liver shrinkage in patients on a low-calorie diet before surgery for reflux. There's a lot going on there. Louise loves helping women to optimise their diet and lifestyle to fight the body composition changes associated with perimenopause, menopause and ageing, such as muscle mass loss and visceral fat gain. Who doesn't have any of that, hey? Louise Mudge, please welcome her.
Thank you. I think I'll just get straight into things to conserve some time. So a good start point for me is really what is bone, because I think we just all think we know exactly what bone is. So back to the textbooks a bit. Bone is actually a living organ, and it's made up of protein, another protein called collagen, minerals, so specifically calcium and also phosphorus, and vitamins. Now, collagen in particular, it gives bone its flexible honeycomb structure so that the bone can be strong to protect our soft inner organs, but also flexible to be able to resist fractures. Now, calcium combines with other minerals to form hard crystals, and it will give bones their strength, which is also known as their bone density. So what I'm going to be really talking about tonight is diet to prevent the development of osteoporosis and preserving bone density. So the prevention of osteoporosis really begins with optimal bone growth and development in youth. 40% of our bone mass is acquired during puberty. The skeleton grows continuously from birth to the end of teenage years, reaching a maximum strength and size. So this is known as our peak bone mass in early adulthood. And this is around the mid-20s for both males and females. So as you can see for males, there's a gradual decline in the bone mass into older age, whereas for females, we're a bit different. So what happens, we have a bit of a plateau over our childbearing years, thank you, and this is followed by an accelerated period of bone loss for several years after menopause and that loss of the hormone estrogen. So I'm not really going to go into this into too much detail, but once our peak bone mass has been reached by our mid-20s, the bone mass and its integrity or density is maintained by a constant process of remodelling, and that's illustrated in this figure here. So more specifically, remodelling is the replacement of old bone tissue by new bone tissue and continues throughout life, so that most of the adult skeleton is replaced about every 10 years. So this process involves the coupling of new bone formation and bone resorption, which is old bone breakdown and removal, and consists of the phases shown here. So the lifestyle factors such as diet and physical activity influence bone development in youth and the rate of our bone loss in later life. The key mineral for bone health is calcium. So a small amount of dietary calcium is absorbed in our blood, and it's used for functioning of our muscles, our heart, our blood cells, and also our nervous system. But as you heard Jane say before, the vast majority of our dietary calcium is stored within our bones. So they're otherwise known as our calcium bank. If our daily intake of calcium is inadequate and there's insufficient calcium in our bloods for essential function, then we start tapping into our bone bank, and this will start to reduce our bone density and increase our risk of osteoporosis. So of concern, 50% of Australian adults don't meet their recommended dietary intake or RDI of calcium. So growing bones require daily calcium replenishment. So I've got the daily dietary recommendations, and you can see that in children, as they're growing, these increase. So calcium is particularly essential during the growth spurt of puberty, and in teenagers require 1,300 milligrams or 4 servings of calcium a day. During adulthood, until menopause for women and 70 years of age for men, we need a daily intake of 1,000 milligrams a day or 3 serves to maintain our bone density. And thereafter, our needs increase again to 1,300 milligrams or 4 plus serves, as less is absorbed from the intestine and more can be lost via the kidneys. So I think we all probably know that a serve of dietary calcium is 300 milligrams, and the best source of dietary calcium is dairy products. So a glass of milk or 2 slices of hard cheese, a pot of yogurt really are our best dairy sources. But for those of us who aren't a big fan of dairy products, there are non-dairy sources. And in preparing tonight, I wanted to keep it quite practical. So I have used brand names. It's not because I favour these products, but if you walk away from here tonight picking up a new product you can incorporate into your daily diet, then I feel like I've done my job. So, for example, regular tofu for vegetarians contains roughly about 175 milligrams of calcium, but if you choose a calcium set tofu, that can be as high as a glass of milk, sitting at around about 350 milligrams. Tinned fish with edible bones are another great source. Now, I'm really going to highlight this because many of us will have tuna, but the idea of having cat food or tinned fish with edible bones puts many of us off. But if you can swap that tuna, and I've actually got a high calcium option of tuna, but to something with edible bones, then a small can does give you the equivalent of a glass of milk. For vegetarians, there's canned white beans, are quite a good source of calcium. Nuts, we always hear that nuts are a high source of calcium. A little bit they give us, not a lot. In particular, a small handful of almonds or hazelnuts are your better options. Tahini, which is sesame seed paste, a tablespoon of that will give us a little bit. Dark green leafy vegetables, they give us a bit, not a lot, and the best of the fruits are really figs and orange. So you can see here that calcium set tofu or tinned fish with edible bones probably really are our best options. Calcium fortified foods have come a long way over the last few years. So John West have a range of about 6 different protein plus calcium rich tunas. One little can will give you 800 milligrams of calcium in a hit. So that they add ground tuna bones into it to give the calcium. There's also calcium fortified cow's milks, and I'm going to touch a bit on protein down the track, but this complete dairy high protein I think is fantastic for aging individuals who I'm trying to optimise their dietary protein, but I'm also trying to give them some extra calcium. So it's a skim milk, and it's giving you almost 50% more calcium than regular cow's milk. And if you have lactose intolerance, which many of our ageing population do have, I frequently see this because we make less of the enzyme lactase that digests lactose. Rokeby Farms have a low lactose option, which is very similar. When it comes to alternative milks, soy milks have come a long way. You do need to check your brands. So some of the trendy brands that we get from coffee shops aren't necessarily calcium fortified, but your brands that you buy in the supermarket like Vitasoy and So Good will give you the equivalent amount as a regular glass of milk. There are also some fortified options. So I've got listed here the Vitasoy Protein Plus, and also their Calci Plus option, which is giving you 400 milligrams per glass. Nut milks, these are starting to become more frequently fortified. I must say, it's very individual. A lot of people shy away from using dairy products, and I think the important thing is we are all individuals, and it really depends on where your dietary protein is coming from. Some people who are needing to watch their weight, perhaps one glass of light cow's milk a day is enough, and then swapping to a nut milk. But if you're going to use a nut milk, you really want to be choosing one that is calcium fortified. So the Vitasoy and the So Good have options here as well. You just need to make sure that you shake it, because otherwise all the calcium's sitting at the bottom of the bottle. There's recently a cereal that's been launched, Uncle Toby's Plus Immune Support. It doesn't give a lot of calcium, but more than a regular cereal, and we have to remember we're putting the milk on top. So ideally, as Jane said, we want to be trying to meet our daily calcium needs via diet, and we really want to be trying to spread that calcium intake out over the day. So Healthy Bones Australia recommend supplementing with calcium and vitamin D3 when our daily calcium intake is suboptimal, but there is the evidence that too much calcium can contribute to calcification of our arteries. So we really want to be careful and limiting our supplements to not more than one a day. And if you're going to be taking more than one, you really need to be having that discussion with your GP or your endocrinologist. You also want to be making sure that you keep your cardiologist abreast of that as well. So moving on to vitamin D. So vitamin D is arguably as important as trying to achieve adequate calcium intake. We need vitamin D to absorb calcium from the food in the intestine, to facilitate calcium reabsorption from our kidneys, for rebuilding and maintaining our bone tissue and regulating our calcium levels in blood. Vitamin D is a fat-soluble vitamin, so it's something that can be stored within our body. We don't have to necessarily be meeting 100% of our needs every single day, but we also need to be keeping track of it. The primary source of vitamin D is sunshine. It's made in our skin when it's exposed to UVB rays, and this type of vitamin D will produce vitamin D3 or cholecalciferol. The dietary form of vitamin D can be vitamin D3, or if it's coming from plants, it's D2. I think really Jane has gone through this, so I might move along, other than to say that about 1 in 3 of us, I just want to reiterate this point, do have a mild, a moderate or severe vitamin D deficiency. So it is important to know our levels if we are at risk. Here is just a list of risk factors, once again, of those individuals who may be at risk of having vitamin D deficiency. I think just something from a dietitian perspective, if we're carrying excess body weight, we can have low vitamin D levels, because the vitamin D can be stored inside our fat stores, and we're not necessarily able to be able to utilise that as easily or to replace lower levels. It's also been shown that smoking or passive smoking can also be associated with low vitamin D levels or having a high alcohol intake. All I really want to say about this slide on vitamin D recommendations from Healthy Bones Australia is, if you think that you are getting some sun exposure but you're not getting it at the recommended levels, then they've put together some handy guidelines as to how much you really need to be trying to get, either through supplements or diet. And you'll see why I put the word supplements first, because trying to source adequate vitamin D from our diet is relatively difficult. For those people who avoid the sun, they need even more, in the vicinity of 1,000 to 2,000 international units per day. They may even need a bit more, and that's when it starts to get into the territory where you really should be having a discussion with your GP about appropriate replacement there. We also need to be making sure that we're having adequate calcium if we're replacing our vitamin D level, so it's not just taking the vitamin D. So the best sources of vitamin D really come from eggs and fish. So if you don't like these, or mushrooms, we're going to struggle. So a regular egg from a commercial hen will only give you a small amount, about 20 to 60 international units a day. Remembering that most of us who might not be getting adequate sun exposure are needing roughly 600 international units a day. So this is just really a tiny drop. If you were to choose chickens, that roam out in the sunlight, their eggs produce 4 times more vitamin D. You can also source vitamin D enriched grain-fed hen eggs, so you're getting closer to that 150 international units again. Cod liver oil, which is a practice that many have done, a teaspoon will give you a really nice dose of vitamin D, but we have to make sure that we're not really taking much more than a teaspoon a day, because then we can start to have toxic vitamin A intake. You would think that eating liver would give you large amounts of vitamin D, but that's actually incorrect. Fish, particularly wild fish caught from the northern hemisphere, will give you so salmon, your oily fish, will give you a large dose of vitamin D, and other types of tinned fish you can find you'll get a decent source from. Light canned tuna is another good source, but you just need to be making sure that you're not having that too frequently, because obviously we don't want to be overdoing it with mercury. Mushrooms, so this is quite surprising. Mushrooms can produce vitamin D2, which isn't as effective as D3, but it is another source of vitamin D. So many of the commercial mushrooms we buy are actually low in D2, but Australian mushrooms recommend we start tanning our mushrooms. So if you grab a cup, or roughly 5 button mushrooms, and you tan them out on a bench for 10 to 15 minutes in the sun, what you'll see is you'll be significantly increasing their vitamin D content by 10-fold. And then if you were to tan them upside down, you increase the amount of vitamin D by 30%. But the real best way is if you slice and tan them, you increase it by 60%. And this vitamin D that you've manufactured, you can actually store your mushrooms in the fridge for just over a week, and that vitamin D will be retained within the mushroom and during the cooking process. So there, start eating more mushrooms. Or if you can't be bothered doing any of that, you can buy vitamin D enriched mushrooms from the supermarket. Vitamin D fortified foods, just in Australia, vitamin D fortification is mandatory in margarine and oil spreads, but you can see the dose is really quite low. It's voluntary for other dairy products. I've got listed here a few products, but really you can see, other than having something like the vitamin D enriched Vitasoy soy protein plus milk, they're not really amazing sources. I think this is something I could have given a whole talk about tonight, and I haven't, but sarcopenia is a word you guys are going to hear a lot about in the future. And when Sonia was introducing me and my study, really what I'm looking at is body composition analysis, helping people to lose visceral fat, to shrink their liver or reduce the fat from their liver before surgery. And when I'm helping them to lose weight, I want to minimise muscle mass loss, because if people are losing muscle, then they become frail, and we need muscles for strong bones. So it's really important not only to think about having a DEXA to have a look at your bone density, but also to be thinking about what's happening with my skeletal muscle mass as I'm ageing, because as we age, we lose muscle mass volume, we lose strength in that muscle, and we lose its function. A tool I use, because I can't just send everybody off for a DEXA, is bioelectrical impedance analysis to evaluate people's skeletal muscle mass. And this procedure takes me about a minute to do, and it gives me really useful information about where an individual's skeletal muscle mass is sitting Do I need to help them to build it up? And then I can start to obtain some information about how do I do this. Now, Erin's going to be talking about exercise and resistance training, and obviously that's really important. But I can also have a look at the individual and work out, are they getting in enough protein for their stage of life? Because I know, for example, younger people don't necessarily need as much protein as what older people do. They can get away with a higher carbohydrate diet than someone who's aging. Do I need to spread the protein over the day? Do we need high biological sources of protein? Do I need to get them to stop intermittent fasting because it doesn't work for them? Do I need to get them to add in protein-rich snacks? Do I need to get them to adjust the balance of their meals? Or do we need to start thinking about a whey protein supplement? Definitely thinking about doing body composition analysis. So in summary, I just want to say that adequate daily protein, calcium and vitamin D are really important for prevention of osteoporosis. We all know dairy products are the best source of calcium, but you can also use tinned fish with edible bones. If you're having alternative milks, please use calcium fortified options and not your trendy organic milks. If you need a calcium supplement, limit it to one a day. Your main source of vitamin D is safe sun exposure. And if you are as you age, if you're frail or underweight, please evaluate your skeletal muscle mass, because this probably needs some work too.
Louise Mudge, thank you very much. I'm not sure I heard much after tanning mushrooms. What do you reckon? That one blew my mind. There's a whole business there, isn't there, that I need to get into. All right, we've heard about medical side of things. We've heard the dietitian side of things. It's time to talk exercise. This might be the most difficult one for most of us, I suspect. So Erin Parish, you've got a job ahead of you. Erin Parish is up to the job though. She is an accredited exercise physiologist and founder of the EP Exercise Physiology and Movement Studio in North Adelaide. She has a passion for creating safe, supportive environments for clients to discover and use movement to manage injury, health conditions, and to feel their very best. And I've got to say, Jane Elliott said when she came in here, she chose both these women and these practitioners to be part of tonight because she recommends them to her clients as well. They know what they're doing, they talk well, and they do their job incredibly well. Erin has a keen interest in women's health, loves working with women through the lifespan to embrace strength training. Now, over the years, she's worked closely with women managing osteoporosis. And then about 5 years ago, EP Studios became the first Adelaide-based location to offer the research-developed Onero program. Who's heard of that? A couple of people, okay. This is for osteoporosis and osteopenia. Since that time, Erin and her team have worked with hundreds of women to use the power of exercise to slow their loss of bone density or improve it, gain mobility and capacity for activities of daily living, to avoid falls and generally feel stronger and fitter. For those of us who have now reached an age where we no longer fall over, we have falls. There's a difference, isn't there? Let's find out what we can do to prevent them. Erin Parish.
Thank you very much. It's an absolute pleasure to be here this evening to be able to talk about a topic that I'm incredibly passionate about. I'm wondering, show of hands, who is currently exercising to support their bone health? This is good, great. So I'm hoping that I can provide a little bit more information around how you're going to be exercising to optimise your bone health. I'm going to skip over this one. It's been covered. We know that it's prevalent and we need to be working on it. So we really want to learn about why exercise is such a key component when you're looking at managing your bone health or an osteoporosis diagnosis. Why do we want to exercise? So as Jane mentioned, often we think about exercise as something we want to do to improve our fitness, so cardiovascular health. But it's more than just that. Also, as Louise mentioned, muscle health is really, really important, and bones. So our bones require specific stimulus so that they can reach their peak bone mass. As both of the previous speakers mentioned, we don't reach our peak bone mass until we're roughly in our mid to late 20s. So if we're not doing things to promote reaching as much bone mass as we can in those early stages through teenage years and in our early 20s, then we're going to be, shortchanged coming into menopause. And in the 5 to 7 years after a woman has gone through menopause, they can be losing up to 1/5 of their bone mass density, which is quite significant. We also want to be exercising to support our capacity to do things, right? So activities of daily living, we want to be able to keep doing those and to feel strong and capable to continue travelling, to play with the grandkids, all of those sorts of things. And then finally, we really want to consider working on our balance, as it's been mentioned, to try and avoid falls. We often talk about what came first, the fall or the fracture. It's generally a fall that leads to a fracture. We don't just fracture and then fall over. So if we can be doing things to help stay strong and mobile on our feet to avoid that fracture in the first place, we are well and truly ahead of the game. So, not all exercise is created equal. What are the things that we want to be focusing on? So there's 3 key components when it comes to optimising exercise for our bone health. And we're going to be going through them today in more detail. So resistance training, I'm going to explain what that is, and heavier than what you might think. Impact training, it's vital for bone health. And balance training. So I consider balance training to be a life-saving skill. I think we've all heard about how having a fall can lead to that decline in someone's independence. And, we hear about someone potentially having a fall and fracturing their hip, and they've gone from being quite independent, living by themselves, to then relying on the help from other people or being in a care home. And that's quite significant. So if we can stop that happening in the first place or delay it, even better. Okay, Jane touched on this. I'm going to bang on it again. So there are types of exercises that won't really do a whole heap for your bones. Doesn't mean that you're going to stop doing them. Keep doing these things if you're already doing them, please. So as Jane mentioned, walking, cycling, yoga, Pilates, and swimming. The reason that these aren't great for bone health is that they just don't provide enough of a stimulus to have a significant impact on your bone density. Fantastic exercise choices, general, and great for your mental health, all that sort of thing. But when we look at bones, it's not going to do much. And in particular, cycling and swimming, your body weight is supported. So that's going to do nothing for your bones. All right, we're going to talk about resistance training. And I'm going to get your involvement, everybody. Can I grab one of those chairs? So, of course, I'm going to get everybody up and moving a little bit. Nothing dramatic, I promise. And if there is something that prevents you from participating or you've got something going on, you don't have to. That's perfectly okay. So, we're all sitting down at the moment. What I'm going to get you to do is stand up. Excellent, that was pretty straightforward, wasn't it? Now, I'm going to get you all to carefully sit back down. We've got those flippy chairs going on, so please just be mindful, carefully sit down. Okay. Now what I'm going to get you to do this time is pop your hands across your chest. Then you're going to stand up again. Good, excellent. So that is a very, very entry-level, basic strength training, resistance training. So we're using the resistance of our body against standing up. You can all sit back down. So when we're resistance training, we are using some kind of load or resistance. Could be our body, it could be a dumbbell, it could be a resistance band, against or through a range of motion. So standing up. Ideally something quite functional, and it's a sliding scale. So as we just did body weight, okay? Right through to, say, using something heavy, which brings me to my next point. Ideally, when we're talking about bone health, we want to be lifting heavy. Now, I know that can be incredibly daunting. I already see people going, oh, I don't know about that. Now, so let me define what heavy actually means. So research does support using high impact resistance training as a way to slow bone loss and potentially rebuild it. So I'm referring specifically to the Lift More study, research information, and the O'Neill program that was developed from that. I'm going to go into that in more detail later, so we'll circle back to that. So heavy, it's all relative. In the studio, when someone's first coming to us and they have low bone density, they're wanting to start exercising to support their bones, generally we're not going to be going, right, cool, pick up this 50 kilo weight. That would be ridiculous. However, over time, with the right guidance and supervision, there's every chance that they can get to that point. So initially they may just start with no weight, a dowel, for example, something that doesn't have any load or resistance to it. And they're going to practice movement patterns, the lifts that we do, really refining their technique to ensure that it's safe. So that brings me to my next point here. Supervision and guidance and correct technique is critical. We want to ensure that everyone is safe, and so hence why when it comes to heavy lifting, we're building you up progressively over time. And like I said, it is all relative. So someone's heavy lift is going to be different to the next person. How much I can lift is different to you, okay? So we only ever compare ourselves to ourselves. Progression is key. We want to be doing progressive resistance training. So we need to keep upping the ante in terms of the stimulus that we're providing to bones so that they're actually going to have to meet that new stimulus. So when our muscles are pulling on the bones as we move through a range of motion, so you're standing up out of the chair, doing not that we do heaps of bicep curls for bones, but muscles are pulling on attachment points to the bones, signalling, hey, you need to be stronger to meet these demands, okay? That's why things like walking, you know, we do it every day, ideally. So our body is used to it. So with the right guidance, there's absolutely no reason why someone with osteoporosis should ever be limited to not lifting anything too heavy. That's potentially something, and I know that it's something, we've had clients be told that, oh, don't lift anything too heavy. What's too heavy? So I remember a client that was told not to lift anything heavier than 10 kilos. She had grandkids. Grandkids weigh more than 10 kilos. They like to be picked up. So it can be very limiting from a functional perspective and for, you know, being able to live your life, right? Okay, impact training. I'm going to get you standing up again. Standing up. Now, I'm guessing some people in the audience do have osteoporosis and low bone density, so I'm just going to ease into this one, and if anything doesn't feel right, please stop. What I'm going to get you doing is just a little bit of a march on the spot. Good, that's great. Now, I want you to go a little bit heavier through your heels so that you can feel a little bit, and we're going to hear it. There you go. Okay, stopping there. That's impact training. So you can feel the impact from the floor coming up through your feet and into your bones, right? Now I'm going to demonstrate progressions on from that. So grab a seat. When we look at impact training and doing something like a stomp, we're doing it with effort, with purpose. I often say, imagine you're trying to squish a bug, or you're trying to get bubble wrap to pop. You know, you have to do it with purpose. We even progress to doing things like jumping, which really does create great impact through the skeletal system. So, as I just mentioned, marching, jumping, all those sorts of things that we can often be advised against, or that we stop doing as we age. It's a really powerful stimulus for our skeletal system. Most importantly, appropriate guidance on where to start is strongly, strongly recommended. We don't start everyone on impact training. It really, really depends on their bone density and many other factors. But it's something that we have to be very careful as we first start out. And small bouts regularly is ideal. So a little bit every day is great. Okay, finally, balance training. I'm going to get you all standing up again. Okay, what I'd like you to do, and again, if you're not comfortable doing this, then that is A-okay. I'm going to get you just having a little bit of a go at standing on one foot, even if it's just for a brief moment. Whoa, everyone's faces. Great. Oh, Jane. Fair. Okay, that's balance training, right? Sit down. Let me show you briefly how we can progress that, because ultimately, with balance training, we want to be progressing that over time. So we might do something like practicing balancing, standing on one foot. Great, awesome. But how does that translate into preventing a fall? So then we might do something like balancing on one leg and reaching forwards. Can we do that? We'll actually practice what happens when we start to fall. How do you catch yourself? Again, life-saving skill. So, as I mentioned before, avoiding falls is key. So if we can better equip ourselves to be prepared for a sudden change in our balance and learn how to fall better, that's going to be really, really helpful and potentially help us avoid breaking a wrist. Another aspect of that is having the strength to get back up off of the floor if we fall over. Yes, everyone's nodding along. That can be quite a significant fear that a lot of people have as they age, that if they do fall over, they can't get back up. So having strength and knowing how to move and use your strength to get up off the floor is vital. Now, what next? So we really want to look at adding to what people are already doing. So I never want to say to someone, stop cycling, it's not doing anything for your bones. Keep cycling, but let's add some other things into what you're doing to support your bone health. And we want to be seeking the right kind of support and guidance. So ideally from an expert. Who are the experts? Well, exercise physiologists are very, very well placed to be helping you with the right kind of exercise for osteoporosis. Even better if you can find someone that has experience with osteoporosis. Even better if you can find someone that is delivering the Onero program. Gold standard. So things that I always like to encourage people to seek expert guidance with is if they're unsure or nervous, they've never resistance trained before, if you've had a fracture. Really, really important that you get the right kind of advice. If you've had one or more falls in the past 12 months, if you have very low bone density, so that's a T-score there, something -3 or lower. If you have any other health conditions, often there can be other things going on, and that will play into how we're prescribing exercise. and of course any other physical limitations, injuries, that absolutely needs to be factored into how we're then prescribing exercise for you. Okay, the Lift More trial. So this was done here in Australia, and it was a 12-month program. They took participants and they either assigned them specific high impact resistance training exercises. So exercises that they were like, oh, this is going, is this going to improve bone density or stop bone density loss? And then the control group got just strength training exercises, but not specific. Now, the findings showed that the exercise intervention group, so the group that got the high impact resistance training exercises, had a great increase in their bone density at the lumbar spine, so of 1%, whereas the control group actually dropped by 1.2% in the lumbar spine. So that's quite significant findings. So from the Lift More trials, that's where the Onero program was developed. So the Onero program is a very specific way of exercising for bone health. It incorporates those 3 foundational aspects, and it has great positive results. I mean, of course I'm biased. I've been doing it for 5 years now and seeing those results. So this is a little snapshot. These are clients of ours, and up on the screen there you can see their T-scores for respective locations, so lumbar and or hip, and then the improvements since attending and doing Onero. They're significant improvements. So it goes to show the power of exercise for supporting bone health and what you can do and can achieve in conjunction with those other elements of medication, diet and supplementation. Okay. So where to from here? Healthy Bones Australia is a wonderful resource for getting started with exercise. They've got some great information on there. The Bone Clinic. So the Bone Clinic, I guess, was part of the Lift More trials, and they are the people that forged the way for Onero. They're based in Brisbane, so it's not super convenient for you guys. However, their website has lots of information around Onero, all that sort of thing. Plus, you can look for Onero providers in your location. And then, of course, the EP Studio. We are a wealth of knowledge when it comes to exercise and bones. We are experts in it. We've been doing it for a long time, and we see great results. I hope that has given you a bit of an insight in how to perhaps improve what you're doing with your exercise for bones.
Erin Parrish, thank you. Thank you. Don't sit down, Erin, because I'm going to ask Dr. Jane Elliott and Louise Mudge to come up, if we can bring the chairs over, because it's time for you, if you've got some questions. We've got our guests here who are willing to answer them. Now, you may have had your questions answered already, because we've had a fairly comprehensive discussion from each of these presenters. But if you do have a question, now, Lena, where are you? We're going to, there you are. Okay, now we need to give you a microphone. If you take the microphone up to Lena. Lena's going to come around with a microphone so you can ask your question. But if you could just help us out, so she's running around, stick your hand up if you've got a question to ask our guests, and we'll get through as many as we can over the next 10 minutes or so. Now, just while we're getting to our first question, I might put my first question to Louise, if I can. One of the things you said about was adequate sun exposure in terms of vitamin D. What's adequate sun exposure? Because we all walk around with long sleeves in face in the wind, our face exposed. Is that enough, or do we need to be walking around with our tops off?
So that's a very good question, and I did brush over that a bit, so my apologies, but basically adequate sun exposure. So it depends on where you live in Australia, and it also depends on the time of year. So ideally in South Australia, what we want to be doing is in the summer months, having exposure for a couple of minutes. So we're sort of looking in the vicinity of about 5 to 10 minutes. And we want to be having a UV index greater than 3, and we want to be doing that somewhere between about mid-morning or mid-afternoon, and then that should give us adequate sun exposure. But then obviously we need to be covering up and slapping so that we're getting safe exposure. And then in wintertime it's a bit more than that, so trying to have some exposure, your arms, your hands, your face, but you're looking at sort of more like 2 to 3 hours per week. Yeah.
Before we ask our first question, the other thing I need to let you know is that tonight's session is being recorded. We're also getting lots of photos taken. So when you ask your questions, if you could say your name, but you may not wish to give your whole name if you're having a few details and that sort of thing, just be aware that this is being recorded if that's an issue for you. Our first question. Just press the button up at the bottom. There we go. That's it.
My name is Patricia Rios. My question is, how to get a bone density test? When is the best age to do this? And do we pay for it?
Yeah.
I'm guessing, Jane, you're the best person to ask for that question.
Basically, your GP can organise it. Anyone over 70 or who's had a fracture can get a bone density either through one of the public hospitals or at one of the private radiology places. Can't hear? Are we not feeding back? It's on.
I might have to use that.
Do that? Okay. I've got it. I'll take that off. Start again. Anyone over 70 not only could but should have a bone density, and your GP can organise that either at a public hospital or one of the private radiology places, and that will be bulk billed through that Medicare. If you've had a fracture, you should get a bone density test. There are many conditions, including some of the ones I've talked about, such as premature menopause, or if you've been on long-term steroids, where Medicare will also cover a bone density. However, there are many conditions where it won't. Just going through menopause at 50, where we've seen that our bone density drops precipitously, Medicare won't cover that, and you can still have a bone density, but you will have to pay for that, and Medicare won't cover it.
And what sort of price would that be, Jane?
It depends where you go, but it could be up to $80 or $100 or more than that. I think it's a bit sad that if we look at it like this, once we've reached 70 or had a fracture, we'll be covered. We're trying to prevent the first fracture, and we have to be, we're trying very hard to get more rebates for bone densities.
Thank you. I'm Marion Saunders from Soroptimist International of Adelaide. We spent 2 solid years getting across Australia a petition to federal government trying to get it in at menopause. We had Prof Nordine here. We turned ourselves inside out. We had meetings. We did everything we could think of over a period. We put it in twice, once from South Australia, then once from the whole of Australia. The first one had 7,000 names. The second one was 16,000 names. And when they had their committee to decide, they went to Perth with Prof Nordine here. They went to Perth, and we had this, the person from Soroptimist ringing me up every 10 minutes. What shall I say about this? What shall I say about that? And we got exactly nowhere. Has anybody tried since?
Yeah, I think Australasian Menopause Society has tried, Healthy Bones Australia has tried, and there are various other conditions, such as women who are on breast cancer treatments. Not even that's rebatable, astonishingly. So there is more work to be done, and it is continuing to be done. I know that, you know, finances do matter, but I'd try very hard to get bone densities if you have got those risk factors. It is important at menopause, yes.
Anybody else got a question? Stick your hand up down here. Oh, hang on, we've got one up there. Come back down to you in just a moment. See, Lena's getting her exercise in.
Thank you very much, Simon Haddad. In regards to strength training and everything, have you ever done, I noticed you did a very nice thesis, have you ever done any studies on, say, impact weight trainers? Are their bone density at maximum levels?
That's a good question. I haven't done any research around that. I guess the types of lifts that were done in the Lift More trials are, you know, I guess your big compound lifts. So something that you might see done with Olympic lifters, that sort of thing. So they don't mess around. They were doing deadlifts, and our clients do deadlifts and squats with weights on their backs, all that sort of thing. So they're proper strength training, and we get all demographics doing it, and doing it with exceptional technique.
I was just going to ask about, I'm Rachel. Hi. I was asking about yoga. I was a bit disappointed that doesn't have that benefit, at least balance training as well. And the second thing I want to ask about, the peak time when you add in your bone density, I wondered whether the impact of COVID, where people had less access to, say, vitamin D, like were staying at home, didn't do their exercise, are we seeing something down the track from here? Do you worry about that thing?
Yeah, that's actually something that I have thought about, and I guess was thinking about more specifically during that time. Let me just go back to the yoga thing. Yeah, it's not going to do a whole heap for your bone density. Balance-wise, absolutely. Flexibility, mobility, that sort of thing. So again, it's one of those things that I would say, don't stop doing it. If you love it, keep doing it. But let's add something to your routine that will actually support maintaining strong bones or improving strong bones. Sorry, Jane. So during COVID, we couldn't run classes like we normally would. So that meant all of our clients weren't able to lift the kind of weights that they had been doing. And that was for a pretty decent chunk of time. Yeah, I was concerned about how that would impact people long term. We kept people moving, which is, again, brilliant, better than nothing, especially just to keep whatever they had built up there so that when they could come back to lifting again, hopefully they hadn't lost too much. So whether we're seeing anything now, I don't know. Jane might be able to play in on this. Yeah, it's hard to say at this point. Bones are slow process.
I was just going to say a couple of things. Do not stop your yoga. I think we mustn't. It's really important that your muscles are strong, and if you've got strong muscles, you're less likely to fall. And of course, it impacts balance. So we're talking about adding something into what you're doing, not taking away what you're doing. I think one of the ways of thinking of this impact training, I sometimes say in a very simplistic way, is that bones like a surprise. So this is, Erin was doing this jumping or stamping. So I say to people, and please don't do this if you're without talking to your GP, but it's really just as simple as I'm saying, if you're going for your walk, which you've always done and you like doing, just maybe hold on to a tree or a light post or something, but give a good jump every now and again. You look slightly mad, you're walking along and you suddenly go bang. Your bones like a surprise. So if you think of that, they like a change of direction or a bang through them, which is what we're talking about with impact training. So, you know, you could add that into your yoga maybe. I don't know.
I think people should be out dancing. Sounds to me like people should be dancing and
Yes.
stomping.
Great.
Yeah? Then you don't even think you're exercising, right?
Exactly, it's fun.
We've got any more questions? Here we go.
Is it on? Hello. Two questions. One to do with calcium supplements. I see two different active ingredients in the chemists, and I'm wondering which is more readily absorbable. And the second one is, I like hiking. Is there a way that hiking can be useful for bone density? Maybe it's the jump every now and then, or carrying a backpack.
I actually think I'm going to hand this to Jane, this question about the supplements. I mean, now what we're seeing is generally calcium supplements. They may start adding other things to them. I think the most important thing we want to be doing is making sure that if we've got low vitamin D, that we're coupling the calcium with that, so calcium plus D3. But in terms of doing other combinations, I really think that's a discussion with a GP or with your endocrinologist. So yeah, I think some of that stuff's a bit fancy, but not necessarily evidence-based.
Maybe you're talking about different sorts of calcium supplements. So the commonest one you would have all seen is Caltrate. That's calcium carbonate. It's the cheapest. It's a completely reasonable supplement. And one tablet's got the 500 to 600. So if you're not having your 3 to 4 serves a day, you can have one of those best absorbed with food at night, one with dinner at night. Calcium citrate, which is a little bit, I think one of the brand names is Citracal. It is better absorbed for some people, and quite a lot of people do seem to get a sort of either a constipation or some sort of upset tummy with the carbonate. They do better on the citrate, costs a bit more. So I think maybe that's what you were talking about, and at night with dinner.
Jane, given you've given a timing for the calcium, what about vitamin D? If you're taking a supplement for that, does it matter what time of the day or when you take that?
No, it doesn't matter, but just not more than either once a day or once a week. Many people I know are taking the mega doses of vitamin D oils, and there's this idea that if you're going to take vitamin D, isn't it better to get a mega dose and whatever? There is an increased risk, interestingly, of falls with mega doses of vitamin D. Now, think about it. You're taking it, you might have osteoporosis and you've just taken something that actually could increase your risk of falls. So I know lots of people do it, but there's no rush if you've got a low vitamin D. Once a day or once a week is enough if you're taking a supplement.
Do we have we've got another question up here? No? Oh, sorry, I thought you were with someone. Any hands up with final questions? Here we go, I'll grab you.
How on earth did someone discover mushroom tanning as a thing?
Yes, I want to know the answer to this one. She's got nothing for you. It's just a known thing, right? Yes. It's just a known thing.
There is actually research into it. Yeah, so it's not, but I'm not actually sure how they came up with the idea of it. Yeah. It's a fungi, it's not actually a vegetable, and they do have a different nutritional profile, and I guess when they were analysing them, they realised they contain vitamin D2, and then thought, well, how can we, concentrate this further? Yep. I know, very cool.
Now, we are running a few minutes late, so if there are no further questions, we might wrap this up, but I want to give you one last opportunity. Oh, here we go. Here's one. I'll race over to you. It's all right, Lena. I'm gone.
I'm coming down anyway. Thank you. I'm Kala. I have osteoarthritis, borderline, and menopause. So am I more prone to have osteoporosis, or it's a medical question, I think?
So you're saying osteoarthritis in the joints?
Yeah.
No, there's no relationship between arthritis in the joints and an increased risk of osteoporosis. So, but if you're menopausal, yes, you're at risk of osteoporosis, but not because of your arthritis.
Thank you.
How are we going? Anyone want to have a last question before we finish up? Oh, there we go. Yes, the hiking ones.
Again, keep doing it. If you love doing it, keep doing it. And like Jane said, perhaps you can add in, some stomping to your hikes.
In
Again,
Australia, snakes.
Snakes,
Just stomp a lot.
yes,
Get rid of the
that's-
snakes.
That's a great point. With making sure that that's an appropriate thing for you to be doing. So keep doing it. But in terms of exercise and doing something that is going to really move the needle in terms of bone density, I strongly recommend everyone looking at and considering, can you add at least one strength training session per week? 2 is even better, but 1 is a great start.
But Erin, if this lovely lady put on a backpack, would that do anything?
Potentially. So there is the great debate of walking and hiking, wearing weight vests, that sort of thing. I'm still a bit on the fence about that because I have concerns around someone that has low bone density putting a weighted vest on and then they're doing an activity for a prolonged period of time and perhaps fatiguing, maybe their posture is then fatiguing. How is that then impacting the spine and putting them at risk for compression fractures like Jane was talking about earlier? So I feel like it's a case-by-case scenario, really.
Oh, look, see, now everyone's getting brave. Now they want to do it. Now when I want to wrap it up.
Hi, my name's Libby. What's the difference in having your calcium tablet in the morning with breakfast or at night with dinner?
Louise can correct me on this one. My understanding is that calcium is absorbed all the way through the day and it's excreted. So we put it in the top end and we're weeing it out all the time through the day. If, let's say we take all of our calcium, including our dairy and our tablet in the morning, then it's great, that's a load there, whereas overnight we're not doing much eating and it seems better to take it at night. Would you like to?
You're spot on.
So let your body be working on the calcium side while you're sleeping, basically. All right. We've got one more up the top here. I keep saying just one more. There might be...
Actually, it's Flora's question. She's asking about vitamin K2. Can we take K2 with D3?
I know a lot of the supplements have got K2 in them. At the moment, Healthy Bones Australia is saying that there isn't enough research to say that that is useful, shall we say. So a lot of vitamins are just expensive urine. I don't know if the K2 is, but Healthy Bones Australia at the moment is saying the calcium is good, vitamin D is good, and the jury is out in terms of research on K2.
All right. Are we calling it? Going once? Yeah. Going twice? Sold. Okay. Now, having said that, we have got some light refreshments up there. Our 3 guests will be hanging around. I'm sure you'd love to go and chat to them and if you've got some more specifics around this. But we do have to say a big thank you to everyone who organised this tonight. Can I just say, she's been running around with the microphone, burning off calories. Lena has put so much work in from the multicultural communities of South Australia to get tonight organised, and I want to say a big thank you to her. And she doesn't even want to be the centre of attention as I give these lovely gifts to our... Oh, you will. Here she is. Good, good, good. We've got some lovely gifts for our guests. Can you please join me in putting your hands together for Erin Parrish, Louise Mudge and Dr. Jane Elliott. Thank you so much for coming out tonight. As we said, this has been recorded so that other people can learn more about osteoporosis. Oh, thank you. I was going to say, gee, I've done cinnamon donuts, now Haig's chocolates. That's a really good combination. Louise Mudge is going to be rapping me over the knuckles right now. All right, thank you so much for coming out tonight. Really great to see you all. I'm Sonia Feldhoff from ABC Radio Adelaide, and thank you for joining us.